So we know that macrophages are very important for the pathophysiology of follicular lymphoma. As a matter of fact, it's impossible to grow ex vivo follicular lymphoma cells unless they are co-cultured with macrophages. And gene expression profiling seminal studies from many years ago clearly demonstrate the gene expression profiling associated with monocytes or macrophage activation associated with the worst outcome in patients with follicular lymphoma who receive frontline chemoimmunotherapy. Hence, it's very important to try to characterize tumor-associated macrophages in patients with follicular lymphoma. And it's also clear that their phenotype may meaningfully change based on the type of frontline treatment that we use. At our center at MD Anderson, we're trying to shy away as much as possible from the use of chemoimmunotherapy for patients with follicular lymphoma, even if currently either R-CHOP or BR do represent in the United States and Europe the standard frontline treatment for these patients. A large randomized phase 3 study called the RELEVANCE study has shown that frontline immunotherapy with lenalidomide and rituximab, also called R-square, is not inferior to chemoimmunotherapy, and NCCN guidelines do allow use of frontline R-square in the United States. So there's an increased use of chemotherapy sparing strategies such as R-square in the United States for patients with previously untreated follicular lymphoma, advanced stage and high tumor burden. However, it's unclear how immunotherapy may affect tumor-associated macrophages, phenotype, and function. So we were able to perform a tissue biopsy before initiation of frontline R-square and at time of relapse in patients with previously untreated follicular lymphoma. And we validated a multiplex imaging assay called VECTRA specific to macrophages. What we were able to demonstrate is that at time of relapse, patients who had previously received frontline R-square tended to have an upregulation of pro-tumoral tumor-associated macrophages, particularly with macrophages overexpressing SIRPα or CSF1R. It's now very clear that the crosstalk between lymphoma cells and macrophages is mediated by CD47 and SIRPα, and the upregulation of SIRPα positive tumor-associated macrophages supports the idea that trying to interrupt this crosstalk may be very relevant on one side for patients who relapse after frontline R-square, but also potentially to enhance the activity of frontline immunotherapy for patients with previously untreated follicular lymphoma. There's currently an industry-initiated phase 1 study looking into a SIRPα inhibitor called CC95251, and we have recently presented some data at ASH and will present more at EHA this year, demonstrating that targeting SIRPα can be very safe, associating mainly just with short-lasting neutropenia that we can control with CSF, and very effective with a response rate as high as 70% in patients with relapsed refractory follicular lymphoma. It's very appealing to try to understand how this agent performs based on this translational data that we recently published on Blood Advances in patients who relapse after frontline R-square, but also combined with frontline immunotherapy in patients with previously untreated follicular lymphoma. And to this regard, at our site, we are currently running an investigator-initiated trial where we are combining R-square to a novel anti-CD47 antagonizing agent called ALX148 from Immuno-Oncology. And we already see very promising signal that we hope to share in the next few months.